Hey guys, so welcome to tonight's session of uh, doctoratorial's residency program, medicine residency program, where we will be discussing about some of the things which can help you predict how which patients of pneumonia will end up going on mechanical ventilation or will require mechanical ventilation. Now, this is an age-old uh, question, right? This is an age-old phenomena. We want to know and predict the rates of about the patients who will end up going to mechanical ventilation or will get more sick, because we want to keep those patients under observation, admit them probably in the ICU, you know, keep them under our care, better watch, right? How do we predict that? So there are multiple things which we have tried to figure out on prediction of mechanical ventilation. From this study came out last year from Germany. So not last year, in fact, this year only. So it came out this year from Germany, and I wanted to talk about this study. So there are multiple things which uh, till now helped us in prediction of patients who will end up going on ventilators. So some of those things are like these criterias, which we have multiple criterias for predicting the severity of pneumonia, like this IDSA criteria for defining SCAP or severe community acquired pneumonia. Then we have our favorite exam question, and something which we use commonly, which we can calculate in the head only because it's easy to calculate, called curve 65. Now, the problem with curve 65 is many people say that it just tells you where to admit the patient. But that has been correlated with obviously the need of mechanical ventilation and intensive respiratory and vasopressor support, IRVS we call it. So it has been used to predict that also, and sometimes 30-day mortality also, although the data is not very strong in favor. But yes, some data exists which says that even severity assessment tool like Curve 65 can help you in prediction of people who will end up going on mechanical ventilation or will require vasopressor support, and even tells you the higher the score, the higher the mortality there might be in at least for the next 30 days. Okay. And then we have Smart Cop, which is the best score for predicting IRVS. Okay. So this is the best score for predicting IRVS or intensive respiratory and vasopressor support requirement. So Smart Cop is there. And then we have the favorite one, the most complicated one, which is the port index or pneumonia severity index. Okay, the port score or pneumonia severity index. Okay, so this tells us more about 30-day mortality, more or less. Okay, so this is about 30-day mortality. Now, the study in talk is came out of Germany, was published in 2026 only, okay, in January. And this study is called Progress Trial. Okay, so this is called Progress Trial. Okay, so Progress Trial. So this is about predicting uh, the need for mechanical ventilation based upon a simple, not scores, but a simple blood test, which we do anyways when we do complete blood count, right? Which is blood eosinopenia. Okay. So it has been observed in this study. So they included around 1,700 patients. Okay, 1,720 something patients they had enrolled, and it's a multi-center controlled trial. Okay, so they predicted that whenever the patient had eosinopenia, okay, less than 30 microliter of eosinophil counts were there in the patient. So those patients ended up needing twice, they had more chances, twice as much chances of going on mechanical ventilation. So around 7.3% of the patient who had eosinophil counts in the normal range or more than 30 microliter, they around 7.3 patients from the group required ventilation, and the group which had lower eosinophil counts, less than 30, 15 something percentage of those patients required mechanical ventilation. So almost double. Okay, so almost twice the size. So this, and it is a statistically significant number. So now the thing is, this is not a new thing. Okay, we have been using eosinopenia as a marker for severity. Okay, as a marker for severity. Now there are two conflicting things here. So we did not know what is the cutoff of eosinopenia we should be using as a marker of severity. Some people said less than 70. Some people said less than 50. Some studies showed less than 50, but we were not very sure because there was no very good data. Not a big data was available. Not a large number of patients were available in those studies. Okay, so they have basically figured that number out. So they suggest that whenever the eosinophil count is less than 30, that is a predictor for going on mechanical ventilation. And the second problem we have here is, so what happens is whenever you use steroids, so most of our patients now post the new IDSA recommendations, post new recommendations by surviving sepsis and everything. So SCCM. So more after new recommendation, most of our new severe pneumonia patients, they end up going on steroids. Okay, they end up getting prescribed steroids, right? So whenever you use steroids, those steroids will anyway suppress eosinophil counts. Okay, so that is one confounder which this study tried to look at also. So even after they excluded the steroid subgroup from the numbers, this was still a good predictor. Okay, so this eosinopenia shows that it is not just a marker of steroid use. It is not getting suppressed by steroid, but it is getting suppressed by the severity of the disease. So whenever there are more interleukins, more cytokines in the body in severe disease, so they suppress eosinophil production, and that is why it is seen that eosinopenia is common in people who have severe disease. And obviously, those severe disease will end up requiring more mechanical ventilation. Now, they could not, so the mortality rate was not statistically significant, although there was a difference, but it was not statistically significant. There was higher mortality, obviously, in the severe group, in the or eosinopenia group, there was higher mortality, but it was not statistically significant. P value was around zero point 0.3. Okay. So it was not very statistically significant. And they say why? Because it was probably total mortality was low in this subgroup. So the median age was around 60 years, okay. And the mortality rate was around 2% or something, okay. So the total mortality rate was low in the study, and that is why they suggest that the statistically significant results were not observed in mortality, but were observed for requirement of mechanical ventilation. Now, how can you use this in your practice? Okay. So that is the whole point of everything, right? How we use those trials in our practice. Does they even make sense? So whenever you evaluate a patient or admit a patient for pneumonia, you see that they have low eosinophil counts, okay, less than 30 microliter. Now you know that those patients you can do, you should also incorporate other tools as well. So all the criterias and all the scores we have talked about, you should also incorporate them. This one marker should never be enough. Okay, you should always incorporate more than one marker or more than one tool whenever you assess a patient. So incorporate those tools as well. But whenever you see, because it is easy to observe, right? Is it easy to catch? Whenever you see a low eosinophil counts, eosinopenia less than 30 microliter, less than 30 per microliter, then you should actually take care of that patient more. You should have a close observation on those patients. You should probably admit them to a step down unit or an HDU or a semi ICU or like an ICU. Okay, if you think that patient requires it, and also if the other scores and all are also suggesting it. And we have used multiple other scores as well. We have used the severity assessment tools like Apache, right? Like SAPS, like SOFA score for prediction of severity as well. So when those are high, so definitely you should admit the patient in the ICU. Okay, those patients require careful monitoring because they are at higher likelihood of landing up on mechanical ventilation and might require vasopressor support as well. Okay, so this is the point of today's class. So I wanted to tell you about these predictors which you can use to know about the severity of pneumonia and the need for mechanical ventilation. Okay, these as pneumonia is one of the most common disease we come across in our hospital practice, in our admission practice. So even in the OPD practice, it is pretty common, upper respiratory tract being more common. But yeah, so you should be aware of this new thing, new study. And yes, this is what this class was about. And I hope this was helpful. You learned something new. And a very good night and all the very best for everybody for the future exams. Bye bye. Good night.
Recording stopped.